Good afternoon and welcome to OC Talk, the show dedicated to helping home health and hospice providers run compliant and successful agencies. Pardon me for a moment. I'm going to get the right screens up for you all. I'm sorry, I'm having a little technical glitch. There we go. All right, we got the right screens. OCTALK aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for OC, and I'm happy to be hosting today's program. This afternoon, we're talking about the fiscal year 2025 ICD-10 coding updates. And now I'd like to introduce our industry guests for this episode. We have Nanette Minton, RN, HCS-D, HCS-H, HCS-O, OC Board Vice Chair and Senior Clinical Coding Manager with MAC Legacy on the call today. Nanette has served in a leadership capacity for over 20 years, holding a variety of roles in the home care and hospice industry, including clinical, administrative, consulting, education, and agency startup and development. And we also have April Swafford, RN, BSN, COS-C, HCS-D, HCS-H, HCS-O, OC Board Secretary, and QA Manager for Symmetry Healthcare Consulting. April has more than 20 years of experience in home health, and she has worked in roles as a case manager, clinical manager, and leader of a cardiopulmonary specialty program. Thanks so much for joining us today, Nanette and April. We have a lot to cover today, so I'm going to just jump right in and we'll get things started. Listeners, if you have any questions for our panelists today, please go ahead and ask them in the chat pane, and we'll try to get to as many of them as we can. April and Nanette, I'm going to turn things over to you, and I'll just advance the slides as we go.
That sounds great, Jan. I'm going to kick us off here and go through the first set of slides here for a little bit, and then April will pick up after that. So good afternoon, welcome. I'm so glad to have so many of you on this call. We are rapidly approaching October 1st, and so we wanted to jump in and provide just a little snippet of the code update. We only have a finite amount of time, so this is certainly not going to cover every code change or code update, but this give you a good idea of some things that are going to affect us on the home health side. So the amount of changes, if you kind of think through that, as you know, they say they're the 2025 changes, but they go into effect October 1st. 252 new codes. Watch out, there's several new excludes ones that have changed to excludes 2, 36 code deletions, and 13 code revisions. Now, those deletions or revisions usually are because maybe there's a newer code that's come in, and so that old code is no longer applicable. So we're not going to spend a lot of time talking about that. Just a couple of reminders that these code changes, it's not based on the start of episode or the start of care date. It's based on October 1st. So we know this sometimes causes problems with those claims every year when the original code is based off the current year versus the upcoming year. So just watch out for that. You'll have to update some claims, and you may want to reach out to your EMR provider and ask them what specific report, if you're not already clear to be able to run to get those corrected. All right. So the first thing we're going to talk about is the lymphoma updates. I don't have a list of all the codes. There are multiple ones, but if you'll look to the right on this box, we kind of give you the code heading for all the different types of lymphoma. Remember, there's two main types, Hodgkin's, non-Hodgkin's, and these new codes are really going to expand the options for those that are in remission or not having achieved remission. This was actually proposed to the ICD-10 Coordination and Maintenance Committee in September of 2022 to really provide a more specific code for those different types in remission. You know, obviously the oncologists need to be able to confirm remission and justify the medical necessity of other services, and if there's not a code available to do that or to more adequately reflect those, then that makes it difficult. Also, we have pre-symptomatic diabetes type 1. Now, this code is going to replace the R7303 pre-diabetes when the documentation supports a type 1 diabetic. And you may see this, these are going to be assigned for early stage 1 that predates the onset of symptoms. You've got pre-symptomatic unspecified, and then stage 1 and stage 2. And I've quoted, we've got the guideline there for you to look at as well. Now, I personally think this is another thing that's coming out of the issues with COVID. At least I have a personal family experience of someone who became a type 1 diabetic after COVID. So it's interesting. That's a personal opinion. So don't quote me on that, but I just like to think through the process behind why the next code set are coming up there. Okay. Another change to look at is we've got an update on hypoglycemia. Again, this is to really try to, thinking beyond what we use these codes for in home health, the bigger picture to codify and look at how they're going to process and the treatment modalities for these different levels. So there's a code for a level 1, a level 2, and level 3 hypoglycemia. The glucose has got to be greater than 54 milligrams per deciliter or less than 70 for type 1, less than 54 type 2, and 3, it's impairing their physical and or mental function. So it might be a different range, but different people respond differently. If they're not used to their blood sugar being that low, they may have physical or mental function impairment, even with a different number. There's also a use additional code note that has been added to the E08 through E13.64 codes to add an appropriate E16 code if applicable. Now, we realize you may not have this information, but you would be able to look at that and code that if the documentation was there. All right, let's talk a second about carcinoid syndromes. So these are going to be used as an additional code to identify any functional activity associated with a carcinoid tumor. And so in the index, we've got add code also the underlying disorders such as primary neuroendocrine tumors, secondary neuroendocrine, or carcinoid syndrome, carcinoid heart syndrome, or other syndromes. So they're talking about the things that happen in the body system as a result of carcinoid tumor. So basically a carcinoid syndrome is, if you don't remember, carcinoid tumors are slow-growing cancers that originate from the neuroendocrine system, and that neuroendocrine system is what produces hormones. So when that tumor secretes hormones into the bloodstream, it can wreak havoc on the body with various symptoms. Some common clinical symptoms would include like flushing, wheezing, GI symptoms such as diarrhea. You can also have cardiac symptoms up to and including right-sided valvular disease, fatigue, and even some cognitive impairment. So that's something that they've really seen that has affected in those patients where they have an increase of the hormones secreted with those tumors. All right, obesity coding changes. Jen, you can go ahead and move to the next slide. Sorry.
Sorry about that.
No, you're good. Okay, so what they've done here is they've added some additional information on, they've deleted the excludes 1 and added the excludes 2. And then if you'll move to the next slide, Jan, you'll see we've got obesity class 1, class 2, class 3. And these do fall into a primary clinical group of A. You must have provider documentation to code, however, just so that you're aware of that. It's just like, regular obesity, just because they're at a certain level, we cannot assume anything on that. But again, they fall into the clinical group A, which is the MMTA other. Okay, so eating disorders. Yeah, here we are. So we don't often see, see this in home care a lot, but certainly if you have a significant psych program or this is a part of another disease process, maybe a history that carries into adulthood. When I think about our home care patients, they've really expanded this and are providing additional information. So we've got anorexia nervosa restricting type, binge eating purging type, and then bulimia nervosa. So they've really expanded those to give us more information about how to code that, and even to the point of, particularly with like bulimia, looking at 1 to 3 episodes versus 4 to 7, 8 to 13, and trying to really tie that in. And then you've got a BMI tying into the anorexia nervosa restricting and binge eating. So obviously we're going to have to look for a lot of documentation on that to ensure we code those correctly, but it's good to have those additional codes. All right, a little bit about epilepsy, and I'm going to cover a little bit about epilepsy and some pulmonary embolism update, and then I'll let April take over. So on the epilepsy coding, so there is a particular gene, KCNQ2, and it provides genetic instructions for making potassium channels in the brain. We know potassium and sodium and all of those channels are electrolytes, keep everything in balance. And when these don't work correctly, there can be too many electrical signals generated, which can lead to seizures. We think about this from a cardiac perspective. You know, when we know somebody's potassium is off, we expect them to have further arrhythmias. We'll think about this in relation to how that those electrolytes, particularly the potassium channels, are affecting the neuropathic pathways. And so this particular gene, there's some type of issue with it, and it can induce epilepsy. Now, it can be self-limiting to pathogenic with difficulty controlling seizures, and then if they have difficulty controlling seizures, you may end up having a host of those developmental disabilities. So, but it's interesting. I have, as of yet, not seen any documentation of this, but as generally happens with our coding updates, it takes a little bit for the clinicians, obviously, to actually be using this particular terminology for us to be able to code. Okay. And so that's, yeah, thank you. So pulmonary embolism. So what we have here is some updates for a couple of different types of embolisms. So there's a cement embolism and a fat embolism. So, and then a couple of these have been added as low comorbidity adjustments. So you'll see the arrow out beside the ones that if you use these, then you're going to have a low comorbidity adjustment. So remember, if it's a cement embolism, it's not going to fall into a clinical grouping, but the fat embolism is going to fall into the MMTA, cardiac and circulatory. So let's talk about why, what a cement embolism is versus a fat embolism. I think I have that on that next slide, Jan. Okay, so it is complicated. A cement embolism is a rare complication when patients have their vertebroplasty or kyphoplasty surgery where bone cement is used. And that's particularly when you think about somebody who has multiple chronic fractures in their vertebra, maybe from osteoporosis or other issues, and this actually leaks out into the circulatory system. Symptoms actually tend to occur weeks or months after the procedures, and interesting, the majority of cases are asymptomatic. Fat embolism, however, occurs mostly after some kind of major trauma, usually to the long bones, femur, tibia, sometimes the pelvis. And then what happens is surgical procedures such as pelvis and knee arthroplasty and IM nailing can also cause the release of fat globules that can lead to a fat embolism. Non-traumatic cases are rare, and then symptoms are usually present 24 to 72 hours after the initial insult. So And usually they're both obviously a result of some type of, you've got some complicated issue happening with this particular patient. So obviously, again, we're going to have the documentation specifically related to this or related to the why in order to code this. So I will now turn it over to April.
Okay, I'm gonna pick up with the anal and rectal fistula code expansion. Now, we already had codes for the anal fistula, the rectal fistula, and the anorectal fistula. They expanded our option on those. So in each of those, what we'll see now is that we have the options of a simple or a complex fistula, and also we will have the initial episode, a persistent episode, or a recurrent episode. So that's going to give us a lot more options under those. We'll also have additional code first and code also notes, so pay special attention to those. Just like Nanette said, not just here, not just here, but through all of the codes, because they really did a lot of expansion on the excludes 1, excludes 2, and a lot of these code first and code also notes. The next thing that we're going to look at is our pruritis. That's a hard word for me. Now, we already had the L29 category for pruritis, and we already had other pruritis. So what they did was expand that other pruritis, and they gave us a cholestatic pruritis, which you may have seen documented before. I know that I have. It goes back to those patients that have cholestasis, where they have that bile that's slowing or stalling, and they get that systemic itching. And so if you see that, we now have a code for it. Now you can see that it's going to fall into clinical group A, which is MMTA other. And next, well, I'm going backwards, sorry y'all. Next, now this one, I would say pay close attention, because if y'all are like me, you see these codes a lot, especially M5136. M5136 and 5137, we have used a lot over the years, and they have expanded the codes on these. Now, what the expansions include is a discogenic back pain, a lower extremity pain, a discogenic back pain, and a lower extremity pain, and then no mention of pain. The differentiating factor on those is going to be the 6th character, and we're going to look on this next slide at just a quick rundown of what that's going to look like. So you can see if we just have discogenic back pain, we're going to have a 0 in the 6th position. If we have low extremity pain only, we're going to have 1 in the 6th position. If we have both of those documented, it will be a 2 in the 6th position. And if we have no documentation of pain, then it will be a 9 in the 6th position. And that will apply to both the other intervertebral disc degeneration in the lumbar and the lumbar sacral. So the caveat is we're not just going to take any documentation of back pain. We want to see that provider document discogenic back pain, because discogenic back pain originates from a very specific area of the spine. And again, that's not going to be all sorts of pain, and we don't have the ability to just look at it and say, well, I think this is where it comes from. So we want to make sure that we have that provider documentation of that discogenic back pain specifically before we use those codes. And you can see on this next slide, it just, what we're going to look at now is a congenital bicuspid aortic valve code. Now, I will tell y'all, as I tell all people, I break out in hives when I start having to use OP and Q codes, because I have not done a lot of pediatric and OB coding. This one is important because it is the most common type of congenital heart defect, and it can occur with other congenital heart defects, such as tetralogy of Fallot or some of those. It is more common in males, and it can result in a serious complication if left untreated. Normally, on your aortic valve, and you can see Q23.81 says bicuspid aortic valve. Normally, your aortic valve has 3 cusps or 3 leaflets that open and close to either let the blood out into the systemic circulation or to hold it in that in that ventricle. What happens with the aortic valve disorder is that you don't develop those 3 cusps or 3 leaflets, you just have the 2, which means that blood is backing up into that ventricle and can eventually lead again to serious complications such as heart failure and those sorts of things. They also added a Q23.82, which is a congenital mitral valve cleft leaflet. Now, the mitral valve normally has 2 valves or 2 leaflets or 2 cusps, you may hear them called. In this, it almost has like a slit in one of those leaflets so that it can't completely close off. So again, you're going to get that leakage of blood. Most likely you're going to hear a significant murmur with that because you've got that blood leaking through. And then we have a Q2388 for other congenital malformations of the aortic and mitral valves. If you do a lot of PEDS coding, you're probably going to see that bicuspid aortic valve. Now this next slide was very exciting for me. What we had before was the T81.32, and I'm sure you've coded that a lot. And that included pretty much everything that fell under an internal operative or surgical wound disruption or dehiscence. Well, they deleted the description up under that T81.32, which we have until October 1, and they opened up more codes to gather specific information on a couple of areas that we see a lot of dehiscence or disruption. One of those is T81.320, which is the dehiscence or disruption of an anastomosis, a repair or closure. The second one is the disruption or dehiscence of an internal operative wound of the abdominal wall muscle or fascia. And I know y'all, if you've been coding any length of time, you have seen both of those documented by a provider as a complication, because we see a lot of those gut kind of wounds, especially in those rotund abdomens that have all that weight that tend to open up. But they continued to keep the other specified internal operative dehiscence, but they also added a deep disruption or dehiscence of an operative wound. So if I'm talking about maybe a cabbage, I'm getting down past that initial opening and I'm getting on down in there, then I may have to use this one right here. But again, I want to make sure that I have the documentation to support it. I'll tell you, it's hard to do a coding update in 30 minutes. These, I'm just going to mention them to you. We do have some additional code for estrogen receptors. If you've coded any breast cancer, a lot of times that you'll find documentation, especially if you look at an oncology note that they're HER positive or HER negative. So we have those, but they've also added others, for example, for your hormone epidermal growth factors, your progesterone, and some of those others. So know that those are there. If you start seeing those receptor codes, receptor documentation, that we have some more options now for that. New aftercare sepsis code. This one I got so excited about. This might have been one of my 2 favorite. We got a Z code, Z51.8 for encounter for sepsis aftercare. We don't have much guidance on it. What we do know that it is not in a clinical group, therefore under PDGM it cannot be used as primary, which if you talk to anybody in the industry, we kind of thought it was going to be, because it's problematic when it's not. We want to follow our provider documentation or query if we have any issues. Just remember right now that it can't be used as primary. I don't know if maybe they're looking to see how much it gets used over the next year, and maybe at some point it will bump it up, because to me, this is excellent for a lot of those patients that we see in home care that have had a sepsis diagnosis in the hospital. But again, can't use it as primary right now. So social determinants of health, and this is one of my all-time favorite soapboxes to get up on. I would encourage you to any social determinant of health that your clinician or your provider's documented to include that, because it is so important for that patient's rehabilitation and their ability to stay safely in the home. They have they've really expanded that Z59.7 to break apart the inadequate or insufficient health insurance coverage versus the insufficient welfare support. So we can tell a difference now, where before they were both grouped together. All right, let's look at some tabular index changes. And probably my favorite favorite one is in here. So they have changed the code first note up under vascular dementia. Prior to October 1, what we have right now is code first, the underlying physiological condition or sequela of cerebral vascular disease. After October 1, it will say code first, if applicable, any causal condition. They made some changes in the code first note under FO2 and also under G21, which is our secondary Parkinsonism. And that's because of the changes in the verbiage in our dementia with Lewy body and Parkinsonism versus neurocognitive disorder and other frontotemporal neurocognitive disorder. To me, it will forever and always be Lewy body dementia, but they have changed the verbiage, so make sure that you read those code first notes closely. Now, do we have another? Okay, this is the one. This was my all-time favorite one that they did this year. Vascular dementia, we know prior to October 1, or what we have right now, is not in a clinical group. So we have to have the underlying etiology in order to code it if it's our primary focus. They have moved it into the F, which is the behavioral health clinical group. So now, yay, it is in a clinical group. So if we don't know the underlying etiology, we can now code it as primary. Couple of caveats. F0150 unspecified still cannot be used as primary. So what you're going to have to do if you have vascular dementia and you're going to have to code, you're going to ask for an etiology anyway, because, you know, we really want to know. I would go ahead and also say, hey, is it mild, moderate, severe? What sort of symptoms are they having? Because even if they don't have an etiology, if I have that severity and or those behaviors, I can code it as primary without that etiology. Now, the next thing is we've not had any updated guidance on hospice. So I would not, until we get something specific that says hospice can use it as primary or as their terminal illness diagnosis, then we do not want to jump ahead and do that for hospice. But again, this was probably my favorite one. Hypertensive emergency, they've added some use additional code. So we want to code, if applicable, any specific organ dysfunction, because we know sometimes with that hypertensive emergency, we can see that. They give you some examples. There may be some other specific organ dysfunction that you see that doesn't fall in here, but if they relate that back to the hypertensive emergency, you want to make sure that you use that additional code there. Now, we also, under hypertensive emergency, know that we already had a code also note that said if patient has hypertensive emergency, we also want to know what type of underlying hypertension do they have. Do they have just benign hypertension? Do they have hypertension with CKD, with CHF, with a combination of the two? But then we have now these that use additional code notes. So just to review, code first or use additional code gives me sequencing. So if I have a hypertensive emergency and I have some of these specific organ dysfunctions, I want to make sure that I sequence those under that hypertensive emergency and then sequence my type of hypertension that I may have. Again, based on what those terms use additional code and code first mean. There's a few changes in our chronic rheumatic heart disease. We know that if we have, for example, mitral and tricuspid, we have a combination code. Those are assumed rheumatic. There was an excludes one that said, okay, if you have those, but then you have documentation that says non-rheumatic aortic valve disease, you wouldn't code that. We would just get those all together. Well, now it's an excludes too. So that means I can capture that mitral and tricuspid valve disease in my 008 code. And then I can also, if I have documentation of non-rheumatic aortic, let's say stenosis or one of those, then I could use that using the appropriate I-30 code, whatever that would be for that. And it's also transversely, they put the same excludes two under the non-rheumatic aortic valve, that I would also include my appropriate I-08 code for my other multi-valve disease if they both apply. Code also note was deleted up under some of our pneumonia categories and added, if applicable, we want to code also any associated conditions such as our abscesses or aspiration pneumonia. That includes the pneumonia categories J13 through J18. Now, I personally tend to use J15 and J18 probably more than some of these others, but you may use some of these others. But know that the code also note applies to all of them. If you want to know all about if you're a nerd like Nanette and I and Jan, and want to get all of the download on all the coding updates, you can go to this website right here. It's a big zip file. You can download it, and you can look specifically at your external cause codes, your drug and chemical codes, all that stuff, and you can look at every bit of it separately if you want to do that.
Thanks so much, April and Nanette. There was a lot to cover, even with just a brief overview. I really appreciate you walking us through all that. And now it's time, just real quick, to give you an update on what's new with AHC, where we share updates from the Association of Home Care Coding and Compliance. And first, we want to make sure you know that it's not too late to order your 2025 coding manual. Decision Health's Complete Home Health ICD-10-CM Diagnosis Coding Manual has been an industry standby for decades and contains so much more home health specific content than just the code set. It really is an invaluable tool. And AHC members get a 15% discount on the coding manual. So be sure to order yours today so you're ready for the changes come October. And you can follow that link in the handouts to go right to the Decision Health store. In other AHC news, I'd like to welcome our newest AHC Advisory Board members. Joining us this year, we have Sherry Parson, RN, HCS-D, HCS-O, HCS-H, COS-C, CEO with Infusion Health. We have Christine Mickel, PTA, HCS-D, HCS-O, HCS-H, Oasis and Coding Team Leader with McBee Associates. Lisa McClammy, BSN, RN, COS-C, HCS-D, HCS-O, Senior Clinical Education Consultant with Mac Legacy, and April Swafford, RN, BSN, COS-C, HCS-D, HCS-H, HCS-O. She is our new board secretary, and she is QA manager with Symmetry Healthcare Consulting. And our new board officers for the 2024 to 2025 term are our new chair, Claudia Baker, RN, MHA, HCS-D, HCS-O, Senior Manager with Symmetry. Our Vice Chair, Nanette Minton, RN, HCS-D, HCS-H, HCS-O, Senior Clinical Coding Manager with Mac Legacy, and Secretary April Swafford, RN, BSN, COS-C, HCS-D, HCS-H, HCS-O, QA Manager with Symmetry Healthcare Consulting. I'm so looking forward to working with all these great folks in this coming year. We hope you enjoyed this episode of AHC Talk. Thanks again to Nanette and April for all the great information, and thanks to all of you for tuning in. We hope you'll join us again for our October call when we'll be discussing the Hospice Hope Assessment Tool. And in the meantime, if you'd like to re-listen to this episode or to a previous one on the go, you can now find AHC Talk on your favorite podcast app. And we will also be adding this episode and the handouts to the AHC website after this call. So if you're looking for those in the future, you can find them on the AHC website. And if you have any suggestions for future guests, topics, or ideas about the format of the show, please send me an email at jan.milliman@decisionhealth.com. Thanks so much for listening, and we'll see you again next month. Take care.